Hello, I'm Sharon Rees and welcome to your topic on prescribing in the elderly. We're going to take a look at why this is a particular group of people when we're considering about the issues of prescribing and think about why older people are at greater risk of adverse drug reactions. And we'll be taking a look at the changes in the body related to pharmacokinetics and pharmacodynamics. And we're going to finish with looking at the current approaches, good practice, and some of the tools used for undertaking medication reviews, a large part of modern practice. And doesn't it sometimes seem that this is the case? People have a list of drugs as long as your arm, not just older people, of course, but quite often we have accumulated lots of morbidities as we get older. And it seems like we're treating not just the medical conditions, but trying to manage some of the side effects as well. So why is it that people are taking so many drugs? Well, we know that there's a variety of reasons, and as we get more and more morbidities, as we get older, people have many more long-term conditions. We see that a significant of older people are taking 4 or more drugs, with the over 65s taking up about half of all the NHS scripts. And when you think about how many long-term conditions there are, ranging from osteoarthritis, multiple sclerosis, other autoimmune conditions like rheumatoid arthritis, obesity counts as a long-term condition, and then you've got your COPDs, your diabetes, and so on. And as we get older, we're more likely to suffer from a more severe adverse drug reaction. It could be a gut bleed, it could be renal failure, that sort of thing. Just to remember what an adverse drug reaction is, there are various classifications, but the most simple, and we can certainly use that for our purposes, are type A reactions, where people have an exaggerated response to something that the drug is supposed to be doing. That could be somebody taking oxybutynin for incontinence and then going into urinary retention, bleeding with warfarin and so on. So often dose dependent. And sometimes this accounts for cross-receptor activity as well, such as when somebody is taking a tricyclic antidepressant and ends up with dry mouth. And then there are the type B reactions, which are essentially bizarre. We don't understand what causes them, and they're idiosyncratic. So what does NICE say? Well, NICE certainly tells us that there are issues with concordance with respect to medicines, not of course just in older people, but we're focusing on those. And the poor concordance with all of these drug regimens does mean that the more regimens there are, the more doses there are, the more complexity, it's less and less likely that people will optimize those therapies. And therefore, the risk of patients suffering harm also increases because we've got more drug-drug interactions, more drug disease interactions as well. And we do know that quite a lot of admissions due to adverse drug reactions are actually preventable. If we take a look at some of the data, what we can see is that the number of people who are taking no drugs, seen here in the sort of turquoise, goes down, slightly up as we get much older, and some people ditch more of their medicines, but goes down. Whereas the number of people taking 10 or more drugs from the age of 60 onwards, we can see this navy blue line going up quite considerably there. One of the things that we do know is that overall we are prescribing more, and you can see the data here that it suggests an increase in the prescribing rates. And why are we prescribing more? Well, there are so many more drug choices. There are lots of new drug classes. There are Me Too drugs, aren't there? And there's also the aspect of patient demand as well. But there is a tendency to think, well, I've got this problem, what's the solution? And often that means thinking about a chemical solution. There are all the aspects of clinical time pressures. Well, I know that this would work and this can increase my turnover and there's a whole load of people waiting in that waiting room. Can I manage the patient with this drug, even if it might not be the very best intervention at this point in time? There is also additional complexity with people living much longer with very complex conditions, such as post-cancer, such as HIV, people that have had grafts, for example. And we run into some very, very difficult, medically difficult situations, and drugs often come into our ways of managing that as well. And the polypharmacy with all of these multiple morbidities is often driven by managing the side effects as well. So we're constantly trying to catch up, aren't we? But we do also know that there's this law of diminishing returns. The more we add in, sometimes the less benefit we get, and yet we start to get more harm. Some drugs absolutely should be used for a given patient. And somebody, say with diabetes, may be on several medications just for that one condition, which tips them into polypharmacy just for that, never mind what else is going on, their asthma that they've had since a child, etc. So where it is appropriate and where the person is getting the best effect from it, and it's the right medicine for the right person, well, that's absolutely appropriate, because medicines remain the cornerstone of treating many conditions. But of course, sometimes a decision is incorrect, it's no longer appropriate, the guideline has changed, it's not the best option anymore. And this is where we're into problematic polypharmacy. And if we just take the example of these prescribing cascades that we get into, and you as a clinician may be entering this at any stage, you may be seeing the person after they've had all of these drugs administered, and you may not know the background to them. So to untangle that when you're doing your medicine reviews, it's actually really complex. Let's take an example. Supposing somebody has a stroke, and after a stroke, they will be put on, it might be a statin, it might be clopidogrel, depending on what the cause of the stroke is. They may have additional drugs right at the start. And say that the stroke is associated with neuropathic pain, quite common after a stroke, and to manage the neuropathic pain, somebody is given gabapentin. Now, a common adverse drug reaction of gabapentin is confusion, and as this person is older anyway, perhaps this is then interpreted as dementia, and now believed to have dementia, somebody gets put on galantamine, and the galantamine causes them nausea and abdominal pain, and as a result of that, they get put on domperidone. And you can see that we're playing catch up here, constantly trying to manage the effects of each new medicine by introducing new drugs quite often, and ending up in this prescribing cascade. And it's worth bearing in mind at this point that whenever somebody comes in with an old problem that's got worse or a completely new symptom, to have the possibility of an adverse drug reaction in your melting pot of differential diagnoses is really quite helpful. We don't have a specific definition for how many drugs is too much. And when we talk about polypharmacy in this term, really we're thinking about problematic polypharmacy. It may be 10 plus that's now considered high, but there are different thresholds that are used. And we do need to appreciate that unnecessary drug therapy can compromise health. Somebody might develop a more severe adverse drug reaction. It might cause somebody to feel really down about their life because they've got so many associated problems. We could affect another drug working properly with additional drugs. And then there's also the additive effect. Say when several drugs are adding to this anticholinergic effect and causing dry mouth, causing constipation, possibly confusion. And we do know that patients are compromised if they don't get the chance to say what they want, because there's the cost as well. You might give it to them, but sometimes they don't end up actually taking it, do they? Adverse drug reactions can be fatal, but often they compromise people's quality of life as well. And we have to think about the appropriate dose as well. And indeed, the BNF advises us to consider, not necessarily do, but to consider halving the dose of somebody once they are an older person. And we're going to look at what the changes are shortly, which may make that appropriate. I think the NICE guideline is quite helpful on medicines optimization. It does recommend that it's a patient-centered process and that they should have the opportunity to be involved with the medicines. We do live in a society where people want an immediate solution, but of course every problem doesn't have a chemical solution, and we do have to consider that when we're thinking about adding in more drugs. Now, what happens as we age that means we're more likely to get an adverse drug reaction? Well, there's lots of changes when we age. We don't have the ability to process a drug through think about the kinetics, absorption, distribution, metabolism, and excretion. These functions can be compromised. And as we add in more and more medicines, you can see here from this list that an adverse drug reaction risk is 13% with the use of 2 medicines. And look how much it goes up to with 7 or more drugs, 82%, very significant indeed. Some of the very frequent issues with adverse drug reactions are things like confusion and cognitive decline. Of course, some drugs can lead to really serious issues like delirium as well. Fatigue, very unpleasant, of course, nausea and various different GI type of reactions. Things like loss of balance and sedation both contribute to the other one there, which is falls, and that can be the precipitating factor for the final decline, a fractured hip, a stay in hospital, the impact on mobility that will have. And all of these will have an effect on somebody's emotional and social life as well, and their relationships, and change in bowel pattern, quite often constipation as we get older, isn't it? Weakness and pain, of course, cause some of these issues as well. The top drug is a drug that we can get over the counter, like an ibuprofen. So non-steroidal anti-inflammatory drugs account for nearly a third of the more serious adverse drug reactions. And these are those that end up in hospital admissions. And that's mostly gut bleeds, but also some renal failure there. Diuretics, we've got volume depletion, renal toxicity, drug interactions, for example, with ACE inhibitors, low potassium levels, muscle weaknesses, good old warfarin, still going and giving people intracranial gut bleeds. ACE inhibitors can cause renal failure. Antidepressants, we've got agitation, urinary retention, confusion, seizures, beta blockers, issues with sudden withdrawal, opiates, respiratory depression, digoxin toxicities, prednisolone, that also could be sudden withdrawal, and that could be psychoses too, and bleeding with clopidogrel. I mean, the list is endless. So let's have a look at why elderly people are more susceptible to all of these issues. Well, aging itself isn't truly a disease. We don't die of old age. But what does happen, of course, is that we see this series of cumulative changes which impair organ function and impair our ability for homeostatic regulation, as you can see here. And we've got altered end organ response coming from all of these different issues. So systems may already be compromised by existing disease, such as lung compromise because of long-term smoking or because of asthma or COPD. But then you've also got, in an individual organ, the time-related loss of functioning units. So, for example, alveoli that don't exchange oxygen and carbon dioxide well anymore. So the accumulation of that, the loss of nephrons in the kidney, for example, lead ultimately to an impaired organ function sufficient to tip us into a more serious status. And when somebody who's older might, under resting circumstances, be coping quite well, things might seem to be going all right. But in the background, the decreased homeostatic regulation side of things means that the feedback loops fail as nerve pathways deteriorate. So, for example, when someone stands up suddenly, normally the barometer, the baroreceptor response means that we compensate. But when we don't compensate, of course, blood pressure in the brain can go down, leading to a fall. A poor temperature regulation can mean a severe winter comes along, and the ability to adjust can be compromised, leading to hypothermia. And we see this also with dehydration risk because there's less thirst signals and we can't concentrate our urine so well as we get older. And all of this will mean that a drug could easily or more easily be the trigger leading to precipitating a change in organ function and leading to something more serious. So as we get older, we're more likely to get an adverse drug reaction, and we're also more likely to get a severe adverse drug reaction. Let's take a look then at absorption, which you see here, distribution, how the drug gets around the body, how it's metabolized predominantly in the liver, and how it's excreted predominantly renal. Well, let's start off with thinking about kinetic changes. And thinking about absorption, well, people are more likely to have surgery as they've got older, so there may be some partial resection that could be because of cancer as one possibility. But also the carrier systems which transport substances across the gut wall are compromised when we get older, and that can lead to the inability to carry certain substances that we supplement across the gut wall. And then the clash between issues with antacids. Many people get gastroesophageal reflux disease as they get older and take antacids because of that. But then those antacids increase the pH because less acid, of course, is being produced, and that delays the dissolution of many different medicines. And you can see a list of them here, including some key ones. We only use digoxin in very serious cases of heart failure that haven't responded otherwise, or of course atrial fibrillation. And we can see anti-epileptics, antibiotics, are very important drug groups. And then some drugs affect GI motility. We've got drugs like amitriptyline, antihistamines that exert a strong anticholinergic effect. And then other drugs like metoclopramide and erythromycin that whiz drugs faster through the gut. And if there's delayed emptying, say in the case of anticholinergic drugs, we might have poor blood flow as well as that, means that the time to get the drug to the maximum effect could be delayed. And that, of course, can be an issue in terms of when the drug actually starts working and delay the time to steady state as well. Generally speaking, these kinetic changes aren't severe enough to warrant dose alteration for absorption. Now, absorption via other routes, that was focused on the oral route. We can think about insulins, for example, taken subcutaneously, transdermal patches, intramuscular depot injections. Well, reduced lean mass as we get older can affect depot injections. And if we think about the normal absorption of insulin after injection, happening with the subcutaneous blood vessels and lymph capillaries. And this happens in the fatty tissue. So if there's increased fat as we get older and reduced blood supply, then this could lead to poor absorption of, in this case, possibility of insulin. Now, first pass metabolism and bioavailability, taking you back to when you thought about the principles of pharmacotherapeutics. If you remember, when we take a drug through the enteral system, could be orally, could be rectally, first pass metabolism means that when the drug gets whisked off, it doesn't go straight into the bloodstream, it goes first to the liver for surveillance and checking over. And if we've got less hepatocytic mass because of the function of aging and losing these little functional units, they also have reduced blood flow. This means, of course, that we've got reduced function. So first pass metabolism may not work as well. So a drug that normally undergoes first pass metabolism will escape and more of it will be around. An example of that could be propranolol. And the increased bioavailability is going to make adverse drug reactions more likely because it's like having a higher dose of the drug. Now, alternatively, a prodrug is a drug where you take the parent compound as an inactive agent, but a process within the body, often liver metabolism, breaks the drug down and releases an active metabolite. Many examples of these, of this, simvastatin, ramipril, codeine, methotrexate, all prodrugs. And if you're relying on the liver to convert the drug to its active form, but the liver isn't working as effectively, less active drug could become available in that situation. Now, volume of distribution is a pharmacokinetic parameter which represents a drug's propensity to either remain in the plasma or redistribute to other tissue compartments. And one of the determinants of that is how lipid-loving or how water-loving a given drug might be. And as we know that body composition changes as we get older, we get more fat composition and we get less water composition. This can have an effect, coming on to that in the next couple of slides. When a drug gets absorbed into the systemic bloodstream, it doesn't travel mostly free. It binds chemically, doesn't have any action, but just binds chemically to many of the plasma proteins and hitches a ride, if you like, around the body attached to these proteins. But at any one time, some of it's free. And only the drug portion that is free to act is going to be able to exert an effect. As we get older, impaired liver function means that we don't produce as many plasma proteins. And as a result of that, more unbound drug may be available to act. And so again, we could see an increased effect of a given drug. So adipose tissue increases differently in men and women, but increases in all of us. And you can just looking at this here, we can see that the fat around the viscera, the fat around compartments between muscles goes up. And essentially, this means that lipid-loving drugs are going to be able to be retained in this greater deposit of fat within the body. And that means that lipophilic drugs are going to be able to, they'll get around the drug as normal, but they can lurk in these deposits of fat, prolonging the half-life because they leach out then over some period of time. And this is particularly important with drugs that affect the central nervous system, which normally need to be very lipid-loving to get past the blood-brain barrier. And so their effects are exaggerated in the elderly, which for psychotropic drugs can carry a number of different very serious side effects. But other drugs are lipid-loving as well, like calcium channel blockers and tricyclic antidepressants. Now, the volume of distribution in terms of water is also relevant, so water-loving drugs, because we lose our ability to retain water. And so if a water-loving drug tends to stay within the blood compartment, but we have less water there, the concentration of the drug in that space is going to increase. And that can have ramifications, for example, when you're thinking about a loading dose for a drug like digoxin, not done as much now as it used to be, but it's still important. And it may be that you need to give actually as much as half as little of the drug in order to compensate for that. And this can also increase the risk of toxicity in hydrophilic drugs, all of which these three named here, gentamicin, theophylline and lithium, all have narrow therapeutic indices. So to increase the risk of toxicity could be to cause a very serious adverse drug reaction. If somebody is taking diuretics, that could be because of heart failure, for example, edema, it could be because of liver problems. That can further decrease the extracellular fluid, which will also increase the concentration of the drug within the body. Now, I've put a cloud with a silver lining down there for you. Ethanol alcohol will have an increased concentration in the blood due to this, so it will be easier to get drunk. Plasma protein numbers decreasing with age can be relevant. We don't always know how much clinical relevance this has, but certainly it could contribute to a problem. If we've got impaired liver function as we get older and therefore lower protein production, let's think about all the proteins that are made in the liver, which is the majority of them. We will have lower levels of albumin, the most ubiquitous plasma protein, lower levels of carrier proteins like the globulins that carry hormones and so on around the body. Lipoproteins could be down, coagulation proteins could be down, and therefore the binding sites, which normally carry a reservoir of drugs around the body, the bound fraction which are inert until it's unbound and free, the drug can't move anywhere. If we've got less binding sites, we have the situation where there's more free drug, and that could enhance the activity of the drugs. Now, this is particularly important for drugs with a narrow therapeutic index and are very, very highly protein bound. And there's some examples for you there. Levodopa doesn't have a narrow therapeutic index, but it is very highly protein bound. And therefore, all of these drugs could have an exaggerated mechanism of an action, so causing a type 1 adverse drug reaction, for example. Now, in states of malnutrition and acute illness, we have a slightly different problem. Malnutrition can mean lower protein levels, so that relates into less protein produced in the liver. But acute illness, of course, can mean that normally the liver responds by producing plasma proteins such as C-reactive protein, acute phase proteins that drive the response to inflammation and infection. And CRP is an example of a protein that actually binds basic drugs in the body. It's called an alpha-1 acid glycoprotein. So binds basic drugs like amiloride, like propranolol, like lidocaine. And by binding them more because levels have gone up, this can then make certain drugs less effective because there's less free fraction. Now, clearance, drug metabolism, this of course is important because we rely on our liver to metabolize a lot of drugs. Some, of course, are not very much metabolized and they might even be excreted whole, but several are, and some have active metabolites as well. And if we've got an issue with CYP450 enzymatic function because of reduced hepatocytic mass, then we've got a scenario where drugs are not being metabolized as effectively. So we're essentially prolonging the half-life and exaggerating the effects of that drug. Phase 2, which is where we get conjugation, is not such an issue. But we do have to be very careful with dosing of medications that are metabolized by the liver in this way. And that could be statins, drug like atorvastatin. It could be a drug used for dementia like donezepam. There's many examples. And you can start to see the theme here, why the BNF suggests that we consider reducing drug dosages in the elderly. Excretion is considered to be the really big noise here when we're thinking about kinetic age-related effects and the reason why adverse drug reactions could happen and happen more severely. Primarily renally driven, excretion will be poorer and will be slower. And we know that after we hit 65, we are considered to be in stage 1 CKD, chronic kidney disease. There will be also increased muscle mass with aging, which will decrease serum creatinine. So this can actually mean that the tests that we use to determine renal function are also potentially compromised by that, because if we're not excreting creatinine well, we would expect to see levels rise in the blood, which will help us determine estimated glomerular filtration rate. But if we've got reduced muscle mass, perhaps we're eating poorly as well, then we don't have that much serum creatinine, so we don't get the numbers and we don't have the same sensitivity to base our drug decision making on. So there is an issue of accuracy there we do need to consider. And once again, important to adjust doses of some medicines, warfarin as an example there, thinking about really avoiding others because you're more likely to get prostaglandin driven renal malfunction if you take drugs like non-steroidals when you are very old. When we excrete drugs, if they're broken down by a good metabolism process, if we don't excrete them as well and there are some elements still floating around, it might simply not matter very much, but several drugs are excreted whole. And if they're excreted whole normally, and then we are not excreting them as effectively, we're keeping them around for longer. They're going to circulate for longer. And examples of these are those water-loving drugs, lithium, gentamicin, digoxin. I mean, theophylline would be another example of that. And we have to be really, really careful for those narrow therapeutic index excreted whole drug groups. There are several others that will be clinically relevant though, and not at all exhaustive, but they will include methotrexate, vancomycin, ACE inhibitors, drugs like ramipril, cinepril, and non-steroidal anti-inflammatories. And that's not to forget the drugs that have active metabolites as well, like diazepam. We've spent a little bit of time thinking about kinetic changes. Well, what about the, the pharmacodynamic changes? We don't have brilliant evidence for the changes that age brings with the end organ response to drugs, but certainly they could exaggerate or decrease our ability to respond to a given medicine. And such changes could be secondary to changes in receptor binding. So, for example, cholinergic receptors are more sensitive, and we find that people are more prone to issues in the autonomic nervous system as we age. A decrease in the receptor number, well, there could be a decline in beta-adrenoceptors, for example, which means that our ability to respond to agonists such as salbutamol could be affected. It could also affect our ability to block them via things like beta blockers. And then there can be autotranslation in a response to a receptor. For example, the cells that muscle and fat cells that utilize the GLUT4 transporter, which utilizes insulin to bring glucose into the cell, may not be working as well, causing greater insulin resistance. But that's also a drug target. It's a drug target, for example, for metformin, and that can blunt the response to our drug interventions. And we do know that there's enhanced responsiveness to anticoagulation. This is possibly because we're producing less coagulation factors as we get older. We don't know this fully, but we do know that quite often INR actually starts to be affected by this and to creep up, and we can actually bring warfarin doses down as people get older. So in summary, all of AD-MNE are relevant to kinetic changes as we age, and there's a little summary there about some of the key points for you. Just to reiterate once again, elimination is considered to be the most important aspect of kinetic changes as we age and problems with drug therapies. We, of course, want to think about the value that medicines deliver to us. Otherwise, why are we taking them? And of course, polypharmacy can be absolutely appropriate. And it's our job to improve medicine's use and optimize it, obviously in a patient-centered way, but we also have to think about cost as well. We have to think about access for other people. We want to know who's going to be at risk and who do we have to pay special attention to, where to focus our medicines reviews, and what tools and processes are there to embark on this process of getting the best out of our medicines while minimizing the harm that can come with them, and certainly enormous levels of waste sometimes as well. And this is a team effort. There's a whole armies of people out there, from nurses, pharmacists, GPs. When people are admitted, they often get a medicines review as well from the hospital pharmacy team. And this is, of course, really important for good prescribing practice and improving patient quality of life as well. Who is particularly at risk from adverse drug reactions then? Well, those with lots of ongoing medical diagnoses. All of these morbidities that we get give us poorer health, increased complexity, and the increased risk of drug disease interactions. That would be something like you want to give somebody a beta blocker, but they've got asthma. So there's an interaction there with the drug worsening the disease. And drug-drug interactions, you only have to consult Appendix 1 to know how complex that can become, to see that you're more likely to cause a problem, stimulate an adverse drug reaction, which could be also from one medicine failing because another was been introduced and then causing a flare-up of a particular condition. The number of doses a day I mean, the more complex it gets, the harder it is to comply. And poor concordance with a regimen will bring upon issues of its own. Recent transfer to or from hospital, there can be a kind of chasm, can't there, between the communication systems. Said before, the pharmacists do a great job on a medicines review. Someone's in hospital for a period of time, they get things done, they get things changed, and then they come out and the GP, the nurse in the community, or the pharmacist isn't sure what's happened and why. And that can mean confusion and patients falling between the cracks. Getting older and with increased frailty, and I've got a couple of slides on frailty coming up. In long-term care settings, nursing homes can be an issue, sometimes because people aren't reviewed as often, issues can be missed. Prior adverse drug reaction, because the scene could be set for an issue that's already there that could pop up again, could be an allergic issue, for example. Cognitive impairment, including dementia, that could be because of issues with concordance, double dosing, that sort of thing. Long-term conditions where things get very complex. Decreased renal function, that most important of the kinetic parameters, and also a low body weight. We don't actually know what influence a high body weight has, just to point that out there. It's very, very poorly investigated. The key therapeutic topic 18 gives us a sense of the two things that are clearly going to go hand in hand. If you've got lots of medical conditions, you're more likely to be on lots of drugs. And then you've got the drugs intended to offset the side effects of all of those drugs as well. And it just points out again that the absolute benefit gained from each additional medicine will reduce as you go on and on. The anticholinergic burden is important, and it's received a lot more focus in recent years because as people are more likely to be on more drugs, this issue of exerting an anticholinergic effect starts to build up. And you can see from the diagram here that many really unpleasant and potentially life-threatening conditions can result of that. People getting dizziness, confusion, hallucinations, sparking something like delirium. This can be very, very serious. Urinary retention, these unpleasant, painful and costly conditions when people get admitted, eye complications, heart complications, and gut, etc. Many common drugs exert an anticholinergic effect. It could be antihistamines, tricyclic antidepressants, which are more often used for things like neuropathic pain. So people may take them at night, something like amitriptyline. Antipsychotics like clozapine exert a significant anticholinergic effect. And some drugs are used because they've got an anticholinergic effect, such as your sulfasenacin or your oxybutynin used for incontinence. What tools are there to help? Well, there's quite a lot of online calculators and manual tables to look at the cholinergic burden, and a score of 3 or above is associated with these the plethora of issues that you saw on the previous slide, ranging from dry mouth to urinary retention to confusion. And I've just put a few of them up here for you. The Aging Brain Care, the ACB, you said ABC, the ACB calculator and MediCheck all do the same things. And an example of the Aging Brain Care one here, the tables where there's a score of 1, usually that means we don't know very much about how this anticholinergic burden is coming about, but it's not particularly severe. But somebody could be on 3 drugs that all score 1 that are having this cumulative effect. But of course, as soon as you're just taking one drug like clozapine, one drug like a tricyclic like imipramine, you then in a situation where you're immediately got a significant anticholinergic burden. Now, frailty. Frailty happens when multiple body systems lose their built-in reserves, and this gives you an erosion of functional, cognitive, emotional abilities, and often this loss of independence as well. And it is this progressive condition, and really we take extra care when we know somebody has got frailty, because this leaves them very, very vulnerable to a whole host of issues, and it can sometimes signal the final stages of life. These are the sorts of things that we see in association with frailty, and you can see mortality down at the bottom there with all those red flags of recurrent admissions, of poor eating. Well, you can see the diagram there for yourself. There is an assessment of frailty that can be done via the frailty index, and you can see some of the figures there. And as we age as a population, we're going to see this more and more. And when we think about frailty and medicines, we can see that this is likely to be people with lots of morbidities, with lots of drugs, and we can see frailty in the center of the pyramid there with aging, polypharmacy and multimorbidity, all really as part of this complexity of aging. Now, delirium is this disturbance in mental ability, and it's this alteration in brain signaling with this reduced awareness of the environment. And it can be triggered quite rapidly, and it could be a dehydration, it could be a medication trigger, a sepsis, that sort of thing. But there are lots of drugs that do induce delirium, and clearly if you're managing somebody for delirium, which is often managed by infection, by prevention and by reorientation, but if you see somebody is on a drug that could be precipitating it, that is part of your management as well. And you can see some very common drugs here, a list of very common drugs that are related to delirium. We talked about tools, and we've had a look at one tool already, the anticholinergic burden scale, which can help you determine whether that burden is getting too much. But I think this 7 steps to managing polypharmacy is quite a nice overall model for you to consider, because a medication review can seem like quite a daunting prospect. There's a person at the center of it, and they'll have their own ideas and their own values and their own goals. And your job is to take their health, their medicines, and to think, does anything need adjusting? Can we do this better? So a platform to support you doing that can be really useful. And I've just done a few slides on looking at how the process moves around this model and some of the aspects to maybe pay attention to for each step of it. In terms of assessing the person, this is where we have a good chat and we also have a good listen, isn't it? Because how does somebody see themselves? Are they one of those people that just goes, oh, you know, the nurse has put me on loads and loads of different medicines, but really I can't see the point in them, and most of the time I don't take them. Well, you know, you've immediately established some aspects of how the person values the drugs and whether they're actually helping or not, because they might not even be taking most of them. And if they're taking some of them some of the time, are you actually getting the effect that you're wanting? Or would it be better to think, actually, we could try just doing without that and see how we go? Thinking about mood and mental health is part of any normal conversation with a patient. Are there any problems that need dealing with? I suppose the point also to make here is sometimes you might do a medicines review and actually end up adding medicines in. It isn't just about stripping patients of their drugs, it's about optimizing how we're managing the person and helping them. And we want to know how it is for them for taking the drugs. You know, there might be a taste that the person hates. There might be a better formulation for them that would improve concordance and the final outcome. And quite often we can't do much without having the baseline tests. We might then want to send the person for an ECG, send them back to a particular team to discuss a regimen with the expert team as well. And what's the status of current morbidities? Is their COPD stable? Is their diabetes worsening? So you want a really, really good chat at this point, don't we? And we do need the frank discussion. We need people to have enough trust in us that we're not going to scold them or anything. What's accumulating in the cupboard under the stairs and what's actually being taken. And this is a good opportunity to also find out, well, what else is somebody taking? Now, that could also, of course, be alcohol. It could be smoking cannabis, but it could also be some herbals that somebody's taken. As people get older, they might fancy some ginkgo biloba because they've heard it improves their memory. And in fact, many herbs can have a significant effect on interactions and the effect that they have themselves. For example, ginkgo having an antiplatelet effect that we may want to know about. And how do they manage the medicines? Are they really organized? Have they got them all laid out for the whole week? Is somebody helping them with it? Or it just doesn't fit into the daily activities and then a lot of the time just doesn't actually get done. And then the goal setting can take place. We need to know what they want. They might say, I just want the pain to go away. I don't really care about anything else. I just want to be able to get on and off the bus so I can go and visit my club. So you need to agree some priority areas. And from your perspective, I guess the patients as well, they might not see it in quite the same way. We want to keep long-term conditions stable with minimum symptoms. I'm sure they'll be on board with improving pain and more mobility and sleep issues. Quite a lot of drugs cause sleep disturbance. It's worth inquiring about that too. We all want to minimize adverse drug reactions and drug-drug and drug disease interactions, and overall improve well-being, encourage exercise. There may be a long list of treatment goals or very short. And the next step is to think, well, what are inappropriate medicines here? And there's no blanket rule on this, but the medicines review tools that we've got are very helpful to give you a sense of what's likely to be helpful and what might not be. And we've got quite a few of them. One of the most commonly used tools to help with medicines reviews is the stop-start tool. Been around for quite a while now, over 10 years. And the idea of this is it's designed to identify medicines where the risk outweighs the benefit, and indeed vice versa, particularly in the elderly population. You can see it's the screening tool for older persons. And it should guide us towards at least questioning, do you really need to be on this particular drug? Now, the recommendations are grouped quite helpfully according to the BNF chapters, and it gives you a red stop item list and a green start item list. As I said before, you might end up introducing more drugs, as well as the guidelines that could be useful to consider. And so I've just put an example here for you for the respiratory chapter. It is considered likely that theophylline, certainly used as single therapy for COPD, could be one to stop because it is a tricky drug with a narrow therapeutic index. We don't tend to keep most people on systemic corticosteroids just permanently for COPD. People might have some exposure in small, short, sharp bursts. We've got to think about exposure to long-term side effects. You're not going to have somebody regularly, so very often on nebulized ipratropium, but check. And first generation antihistamines, what about the issues with chlorpheniramine and falls and the anticholinergic burden? And we all want to inquire about falls. We want to start with good practice. We're thinking about how to manage asthma with regular therapy, and we think about some preventative therapy maybe there as well, and reviewing patients with COPD and following the NICE guidance, which is beneath for each one of them, as you can see there. The no tears tool, and you can see in pink down the side here, that's no tears as you look through. Do they need the drug? What was the original indication? Do they still have the problem? Some people over time, the problem will go. Asking open questions, getting the right tests, thinking about the evidence. Is the medicine causing an adverse effect? What risk reduction can we introduce? And can we simplify things? It could be simplifying a regimen. It could be switching to something that's only a once a day, once a week medicine. Then there's the medication appropriateness index. This is an Antipodean one, and it asks these questions and then looks at, it gives a score for each of these and then weighs it up. And of course, you want to know that there's a proper indication, are the directions correct, and so on. So they all do the same thing, via a slightly different way. Assessing each medicine individually for risks and benefits, and we employ these tools just to do that, don't we? And we want to know these sorts of things. Do we still need the medicine? If it's still needed, is it still working? I mean, the person might still have the condition, but they might say, well, I don't think it helps at all anymore. It used to be quite good. We do sometimes become tolerant to things. Some medicines become less effective over time. An example of that would be use of salbutamol as we develop tolerance. What about the evidence for use? It might no longer be the first line drug for that condition. They might have been on it for 20 years. Is taking it a problem for the patient? That could be practically or because of an effect of it. Are there any adverse drug reactions? I mean, it might still be doing something, and if it doesn't bother them, it doesn't cause a problem, could we consider leaving it? Is a prophylactic intervention needed if the goals are long-term? These are where we run into some slightly more tricky, and we have to consider the ethics of such decisions. If somebody is now frail, if they're maybe in their last year or less of life, do we want something, for example, not exclusively, a statin, for which the goals are very long-term in reducing the risk of cardiovascular events? And that's something that you're unlikely to make the decision on your own for, and it's something for discussion with the person and their family. Is the drug contributing to a separate issue? The anticholinergic burden is an example there. Are there drug disease or drug-drug interactions? At the time when somebody was put on a drug, they may not have been the disease, but they've now since developed the problem, and the drug could be making a problem worse. Are there palliative care considerations? Well, if somebody is having palliative care, there's going to be different priorities in the last phase of life, even if that is quite an extended period of time. And we want to centre what happens around that person's preferences and improving their quality of life. Stopping or reducing the dose. This is what the King's Fund has to say about this, that most medicines actually don't need to be used lifelong, and we often don't have the evidence for lifelong use for medicines, for example, opioids for chronic pain, and we need to frequently reassess the risk-benefit profile of medicines. And we don't have great evidence about supporting decisions to stop therapy. That's the reality of it, and that's why medicines reviews can be quite difficult to do, quite time consuming, and can make for some quite difficult discussions, not just between you and the patient, but you and the other teams as well. And clinicians often feel that, well, if somebody else has put them on that drug, who am I to take them off? And who's going to support me if I do that? And these are very worthwhile questions, don't have easy answers. The situation from all the previous steps will have occurred before you make any changes, and you may need to liaise with, it could be the GP, the cardiovascular team, before you can make the decisions that you want. So you can say, I'm considering doing this. I think it would be useful because of X, Y, and Z. What's your opinion? Look forward to discussing it. And we do need to think, if you're thinking about stopping a drug, supposing it was something like prednisolone, will that cause problems because somebody's been on it for a long time? Sometimes you can't suddenly stop drugs. You don't suddenly stop ACE inhibitors and diuretics. We don't suddenly stop Parkinson's drugs. And we also don't usually want to interfere with certain categories of drugs. Disease-modifying anti-rheumatic drugs, for example, anticonvulsants. So there are lots of issues with some long-term drugs for some long-term conditions. And there are many tools to assist you, as I said before. 6 and 7 on the NHS 7 steps: monitor, adjust, and reassess. It's an ongoing process. We're continually making sure that we're along the right path, doing the right thing. And as we make each change, we want to check that it's okay before we maybe proceed to making any more changes. So we do need to review this continually. There are lots of resources and references to help you in seeking expertise in polypharmacy, in prescribing the elderly, and in medicines reviews. And here's just a few of them. Some of the others are actually on the slides as well. And it's quite useful after undertaking any talk to think about what you can take out of the lecture. What are the key aspects for you, and what relate particularly to your type of practice and your patient demographic? Could there be any new tools that are suggested here which could support your practice in the future? Would you give something a go, maybe try a new tool out? Have a look at the Medicheck anticholinergic burden site, for example. And what clinical or prescribing changes might you make? What system or note-keeping change will you make? Will you write down checked for drug-disease interaction? Are there any additional safety netting or counselling measures you'll consider? So that could be how quickly you review somebody after the change. It could be how you go about having the consultation for the medicines review. And are there any previous or new guidelines relevant to your practice that you can take a look at now? There's the CKS do an adverse drug reaction link, which is quite useful, for example. And are there resources you'll access to support learning? The anticholinergic burden score online could be an example of that. So that brings me to the end of the recording. Thank you very much for listening.